Hi, everyone. I am Jennifer Webster. I am an attending physician at the Children's Hospital of Philadelphia in the Division of GI, Hepatology and Nutrition. I will be talking about pediatric gastroparesis today. I have no disclosures. So I thought I'd start off by presenting a common case that we see very frequently in the outpatient GI office. This is a 15-year-old female who presents with progressive nausea and bloating after an episode of viral gastroenteritis, a GI bug, about 3 months ago. She has had some intermittent vomiting, which can occur up to 2 hours after a meal. She has a sensation of fullness even after eating a small amount of food, and she's lost 2 kilograms in the last 3 months while she's been sick. She was previously healthy and on no medications, and there is no family history of GI disease. She was first seen by her pediatrician, who did a trial of famotidine to see if this was related to reflux, but had no improvement, so then switched her to a more effective reflux medication of omeprazole and had continued vomiting and weight loss. The pediatrician ordered blood work, which was normal, as well as an upper GI study where she swallowed barium and had a normal upper GI with no evidence of abnormal anatomy. And then she came to us. And so our first thought was to get a gastric emptying scan to look for gastroparesis. So she was then referred to the GI office and we ordered a gastric emptying scan, and here are the results. So as you can see, they measure how much has been emptied at intervals of time, with 7% emptied at 30 minutes, 12% at 60 minutes, 18% at 120 minutes, 25% at 180 minutes, and then 40% at the end of the study at 4 hours. Ultimately, with this result, she was diagnosed with gastroparesis, which is what we will be talking about today. So to start off, understanding what gastroparesis is, it's always best to understand what normal gastric motility or movement of the stomach is. And there are different parts that the stomach is in charge of when it accommodates and brings food into the system. So the first is that relaxation and accommodation to allow the food and the liquid to fit into the stomach. This mostly happens in the fundus area of the stomach, which is the largest part, and it's mediated by the vagus nerve. With this function, the stomach can actually increase its size by 2 to 3 times. So it can allow as much food or water in as you would like. After that, then the stomach has to empty out the contents into the intestine. It does this by contracting the fundus in the antrum, which is another part of the stomach closer to the end. And it also stops the contraction of the pylorus, which is the entrance into the small intestine, as well as stopping the contractions of the small intestine to allow that stuff to flow into there without any contractions the other direction. And so knowing this, we then think about what gastroparesis is, or delayed emptying of the stomach. So gastroparesis is a chronic gastromotility disorder, motility meaning movement of the gut, with delayed emptying of the stomach. The impaired function is in the nerves of the stomach, and it fails to stimulate the smooth muscle contractions, which is this emptying portion of the motility of the stomach that we talked about in the stomach. Most patients present with these symptoms, which include nausea, vomiting, bloating, early fullness, abdominal pain, and weight loss, as we talked about with the patient presented previously. And nausea is typically the most predictive symptom of abnormalities on the emptying scan or diagnosis of gastroparesis in children. There are many different risk factors and potential causes of gastroparesis. Overwhelmingly in children, it's considered idiopathic, which we typically think is post-infectious, but there are specific other causes that we consider when we see patients with gastroparesis listed here, including inflammatory disease or chronic illness, connective tissue disorder, anatomic abnormalities, trauma and critical care, malnutrition, and dysautonomia. So to go through each one of these in a little bit more detail, post-infectious or idiopathic causes, which again is the most common cause in children, is typically thought to be virally induced, although we don't always know that there was a virus. In the case that I presented previously, the patient did have symptoms of a GI bug or viral gastroenteritis about 3 months prior to the presentation, which would be very typical for a case like this. Commonly, EBV and CMV or mono, rotavirus and norovirus are causes of gastroparesis, but we see it with any viral and sometimes bacterial infections as well. Inflammatory and chronic illness are also potential causes or triggers to gastroparesis. In kids, this can include milk protein allergy in small children, also celiac disease and diabetes. In adults, diabetes is a very common cause of gastroparesis, although we see it much less commonly in children with diabetes, and is not something that we typically think about in this population. Previously, we felt that the inflammation of the stomach was the cause of the delayed emptying, but now as time goes on, we're seeing that the inflammatory disease itself may be the trigger of the gastroparesis despite having gastritis or inflammation in the stomach or not. So patients with celiac disease, for example, may not have inflammation on biopsies of their stomach, but they may have symptoms of gastroparesis because of their overall inflammatory response to the disease itself. Connective tissue disorders associated with gastroparesis include Ehlers-Danlos, hypermobile type, muscular dystrophy, and mitochondrial disorders. Muscular dystrophy is very complicated, but it has a lot to do with the smooth muscle involvement of the disease and the ability for the stomach to empty because of the abnormalities in that muscle. And mitochondrial disorders is also very complicated, but it's extremely common in patients with mitochondrial disease, with up to 70% of children who have mitochondrial disease with delayed emptying of their stomach. Anatomic abnormalities, which increase your risk for gastroparesis in children, include congenital diaphragmatic hernia, which has a lot to do with fetal abnormalities and development, tracheoesophageal fistula. Similarly, the upper GI tract is formed abnormally as a fetus and therefore does not function normally when they're older children. Malrotation and fundoplication, which is a surgical intervention which can often cause gastroparesis, and we sometimes have to compensate for the surgical complications like gastroparesis in these patients. Trauma and critical care, so patients who are very sick have a higher risk of having difficulties with delayed gastric emptying, which often has to do with medications they're on, but we also know that intracranial trauma can be a specific trigger for gastroparesis, likely related to the functions of the nerves. Prematurity has higher risk of having gastroparesis, again, probably having to do with the development of the enteric or nervous system in the gut. And critical illness, like I said, patients who are critically ill often have delayed emptying of their entire GI tract, including the stomach. This can make things very challenging for patients who are very ill because having the slowed emptying of their stomach and gastroparesis can make these patients at higher risk for aspiration. And so deciding on enteral nutrition or nutrition through the gut can be complicated at times. And malnutrition, this is a known cause of delayed gastric emptying. It was first seen in patients who were very malnourished with kwashiorkor. It can be extremely difficult as far as treating patients with gastroparesis because, as we stated earlier, and in the case that I presented, gastroparesis itself can cause weight loss and malnutrition and therefore cause worsening of the gastroparesis. And this cycle is very difficult to break, and the malnutrition that is caused by the gastroparesis itself then exacerbates the disease. So despite this, nutritional rehabilitation is an excellent cure for gastroparesis that is caused by malnutrition itself. Obviously, if gastroparesis was the cause of the malnutrition, it can be complicated and nutrition alone won't help, but often for patients who have lost weight for other reasons, it can be reversed with rehabilitation of their nutritional status alone. Dysautonomia is also associated with gastroparesis. There's a lot of variability in the reporting of how frequent gastroparesis happens in patients with known dysautonomia. One study did show about a third of patients with orthostatic intolerance or POTS have gastroparesis. And in another study, they found that 72% of patients had delayed gastric emptying in a cohort of patients they studied with dysautonomia. Despite the variability, there is evidence that patients with dysautonomia tend to have worse symptoms of gastroparesis compared with patients who do not have dysautonomia, regardless of how much emptying their stomach does. So how do we diagnose gastroparesis? There are multiple different ways to diagnose, including gastric emptying scintigraphy or gastric emptying scan, as we often say, Antroduodenal Manometry or ADM, the SMART pill, and a breath test. So gastric emptying scintigraphy, it is very difficult to use in pediatrics. The normative data is not available for children, and our norms are based off of the adult data. So it can be difficult to interpret, but at this time, it continues to be the gold standard of diagnosis. And as we saw in our patient, is how we diagnosed them with gastroparesis. The gold standard is a 4-hour solid gastric emptying scan, which includes ingestion of an egg meal, which is cooked with technetium radiolabel. We talked about the findings in our patient previously with how much was emptied at each time interval, and the cutoff at the 4-hour mark, which again is the gold standard, is 90% emptied at 4 hours. Sometimes they're reported in how much is retained, and so anything more than 10% retained at that same time would be abnormal. If you go back to our case, if you remember, she emptied 40% at 4 hours, which is a pretty severe delay in the emptying and consistent with the diagnosis of gastroparesis. Despite this being the gold standard, and again, with some difficulties in interpreting it in children, it isn't the most specific test in the world, but it is what we have right now. So what we do know is that delayed emptying is always present in patients who have gastroparesis, but it isn't necessarily diagnostic of gastroparesis, and some patients have delayed emptying on this scan without any symptoms of gastroparesis, which can be quite difficult to understand. Particularly in infants with reflux, many of them have delayed emptying on their scans, which are typically liquid emptying, and so again, difficult to interpret. And patients with other types of intestinal dysmotility also often have delayed emptying on their scan, whether or not they have symptoms of gastroparesis itself. The other complicating factor in all of this for children is that there is no standardization for how we do these testings in different institutions. And although the 4-hour scan is our gold standard, many institutions do 2-hour scans or less because of difficulty with tolerance or difficulty for patients to stay there for the whole study. So all of this makes it much more difficult to diagnose in pediatrics than the adult population. Antroduodenal manometry is another potential way to diagnose gastroparesis. It is done with a catheter that goes from the nose to the small intestine. The catheter has ports that can pick up pressures indicating movement of the GI tract. Here are a couple of examples of tracings for an antroduodenal manometry. This first one here is a normal study. The spikes in the study indicate pressures. You can see here, this port would have been in the stomach and the rest of them would be in the small intestine farther down. And there's spikes all over the study in the tracings. This one here is an example of gastroparesis. You can see this top line here, which is the stomach, would indicate no movement at all, which is exactly what we define as gastroparesis, and the remainder of the intestine moves normally. Although this is a good study, it is more invasive. The catheter has to be placed often under anesthesia because it's uncomfortable to place. And there is no normative data, again, in children, which makes it difficult to rely on as your primary way to diagnose. So we still go back to the gold standard, which again is more common in adults, but gold standard for pediatrics as well, of the gastric emptying scintigraphy. The SMART pill is a wireless motility capsule, which records pressures and movements of the intestinal tract as it moves through the system, as well as levels of acid to indicate where in the intestinal tract the pill is. This here is an example of the results of a SMART pill with a patient who does have gastroparesis. And that is based on when there's a change in pH from coming out of the stomach into the small intestine, based on the fact that we know the stomach has higher acid levels than the remainder of the GI tract. It took 5 hours for the pill to pass through this area of the GI tract with high acid levels or a low pH, as you can see here. Once it hit this level here, that means it's passed to the stomach into an area with less acidity or a higher pH, and that's when we know that the pill has emptied through the stomach. Right here is the time below, and you can see that it took about 5 hours, which is beyond our normal 4-hour mark, as we know from our gastric emptying scintigraphy. There is only one study that has been done in pediatrics using the SMART pill, and it does seem to be very sensitive, but not necessarily specific when compared to 2-hour scintigraphy. So again, this goes back to some of the standardization issues that we have in pediatrics. The breath test is available to diagnose gastroparesis. It is a test that uses a non-radioactive isotope label on a solid component of a meal. The patients have to fast overnight, and then prior to taking that meal with the label, they use their breath to take samples. Then they eat the test meal. It has to be completed within 10 minutes. And then breath samples are gathered at these time intervals of 45, 90, 120, 150, 180, and 240 minutes. This, again, is not well studied in pediatrics. There does seem to be a high sensitivity when compared to the gold standard of a scintigraphy in one study, but we don't know for sure. In pediatrics, there needs to be more studies. What is nice about it is they did compare testing results in patients repeatedly, and it seemed that there was very good intra-individual reproducibility, meaning that the test was very consistent in the same patient multiple times, which is something we sometimes have problems with the other testing. So now that we've diagnosed our patient with gastroparesis, what options do we have for her? So the treatment options vary, obviously, and here are all of them, including diet, prokinetic medications, or medications that encourage movement or motility of the GI tract, antiemetic medications or anti-nausea medications, medications to alter gastric accommodation or that relaxation of the stomach that we talked about previously, endoscopic procedures, surgical procedures, neuromodulation, and then psychological support. So dietary treatments typically include small, frequent, low fat and low fiber meals. Additionally, we recommend that patients try to identify specific triggers that may be common for their own body to trigger symptoms of their gastroparesis and may vary from patient to patient. We also recommend that patients chew their food very well and sometimes drink fluids to help move the food through the system. And we do recommend that patients limit carbonated beverages because those can fill the stomach with gas, which can stretch it more and cause some of that discomfort and bloating. This is where we try to start as long as patients are overall well appearing. The patient that we presented earlier had already had a significant weight loss, and so starting by limiting meals or changing her diet may not be a good first step. A little bit more aggressive type of dietary treatment is post-pyloric tube feeds. This is a tube that goes from the nose past the stomach into the small intestine, or sometimes directly from the stomach and then gone through the small intestine so that you can bypass the stomach completely and you are just not using this dysfunctional organ. This is really helpful in a setting of significant weight loss to nutritionally rehabilitate patients. Again, talking about the potential causes of malnutrition and that cycle that these patients get into. If there is a thought that nutrition itself was the cause of the gastroparesis, this is a great option to rehabilitate quickly and efficiently and cure the gastroparesis. If gastroparesis was the potential cause of the malnutrition, this may help with that cycle since you're getting rid of the stomach completely and you can get nutrition into the body without having to use a dysfunctional organ. Overall, it has really good outcomes. There is studies showing that there's a reduction in overall symptoms once the tube is placed and the stomach's no longer being used, and there is a reduction in hospital admissions. This is an aggressive way to give dietary and nutritional rehabilitation and is not always accepted, obviously, as the first line treatment, but it is available. So, okay, we don't want to do diet, we can't, or the tube feed seems a little bit too aggressive. What about some medications? So the first round of medications we will talk about are prokinetic or movement or motility agents. These include erythromycin, metoclopramide, cisapride, and domperidone. Erythromycin is actually an antibiotic. It is used at doses that is not able to kill bacteria, but actually does bind to motilin, which is a receptor in the stomach that actually causes the contractions. And by binding to the motilin, it helps move the food to the stomach. It also helps promote the relaxation of the pylorus, that last area where the food needs to flow through into the small bowel. And it comes in a liquid and tab formulation. And so that's very helpful in our smaller infants or our younger children who can't take tabs. And so it's often a first choice for our patients. The next one to talk about is metoclopramide. It's another effective medication for gastroparesis. It works by normalizing any abnormal movements or dysrhythmias of the stomach and improves symptoms significantly by increasing the emptying. It is not currently a first-line therapy for our patients because of a black box warning, which includes extrapyramidal side effects such as tardive dyskinesia. This is typically a reversible side effect, but it is quite concerning when it happens, and so we don't often use it as our first line. We typically use erythromycin first. Cisapride is a pro-motility medication that increases contractility and accelerates the food emptying out of the stomach or liquid emptying out of the stomach. Unfortunately, it was withdrawn from the US market because of potential cardiac side effects. It is still sometimes used as an investigational drug at some institutions in some of the more severe cases. Domperidone is another medication that's unfortunately no longer available in the US. It is similar to metoclopramide in how it functions by moving things through. It's also an antiemetic or anti-nausea medication, but again, it has potential cardiac side effects and was pulled from the market, and it is only used as an investigational drug right now. So further medications that could be helpful, antiemetic or anti-nausea therapies, they're often not helpful alone, that can be super helpful as an adjunct along with some of these motility medications or dietary alterations to help with the treatment. The three types of antiemetic therapies we use are serotonin antagonists, antihistamines, and low-dose tricyclic antidepressants with the specific types of medications listed underneath them all. They are all very helpful for nausea, but again, nausea treatment alone is probably not enough to treat gastroparesis. And then medications to help with gastric accommodation or that relaxation of the stomach. So these medications include cyproheptadine and buspirone. Cyproheptadine works by improving the gastric accommodation, and it also has this added benefit of decreasing sensitivity of the nerves in the gut. And so for patients who are experiencing pain associated with their gastroparesis, this is a very good choice. It allows the stomach to stretch more or relax more. And because of that, there's more room to fit food in, and you don't feel quite as uncomfortable when you are eating. But a side effect due to that is increased appetite. I will say this is a side effect that is very welcomed in the patients who have lost weight. And so another good reason to choose this medication in children who have pain and weight loss. In one study, it showed pretty good effect with about 50% of children seeing some symptom response with this medication alone. Another medication that can improve gastric accommodation is buspirone. It again also relaxes the fundus or allows more space in there. And another added benefit, if there's a patient who is experiencing anxiety as well, is it is an anti-anxiety agent. So what about more invasive endoscopic procedures? So there are two that we sometimes use, pyloric Botox and pyloric balloon dilation. This picture here is a picture of the view that we see with our endoscopy scope, and then the needle going into the pylorus, which is the opening between the stomach and the small intestine, which you then use to inject the Botox. There does seem to be a very good response of Botox in children, and it lasts about 3 months, which can sometimes be life-altering for patients who have been extremely ill. It just works by paralyzing those muscles and allowing the food to more easily flow through to the small intestine. Balloon dilation is not frequently used in pediatrics. It has been used in adults more often, and the data is promising. It similarly works to Botox, where you're affecting the muscles that are in function between the stomach and the small intestine. And so by ballooning them or stretching them, it allows the food to move through more quickly and therefore has similar outcomes to Botox. And then surgical procedures, we very rarely, if ever, recommend surgical procedures in these patients because in pediatrics, it is typically an idiopathic cause or a post-infectious cause. The surgical procedures include pyloroplasty and pyloromyotomy, where the pylorus, that same area of the stomach we just saw in the last picture, those muscles are removed or incised to allow things to flow through more easily. There is some data that thinks that there could be some side effects, including reflux, if there isn't a fundoplication or a tightening of the lower esophageal sphincter between the esophagus and the stomach, along with the procedure, with the surgery. And right now there is no pediatric data, and so it is not a recommended treatment modality in children. Neuromodulation is a newer treatment modality that's available for gastroparesis. It is a high frequency, low amplitude current that is delivered as a pulse into the stomach. Initially, patients will have a temporary pacer placed outside of the body, and if there is good response, then this same device will be placed surgically. The theory is that the stimulation of the enteric nervous system or the gut nervous system improves with this pulsing, and therefore the vagus nerve has improved signaling and allows the stomach to relax better. And then psychological support. We often use psychological support as a part of our treatment for patients with gastroparesis because it can be such an uncomfortable experience, and a lot of the side effects like bloating and weight loss can be extremely concerning for these patients. The goal of psychological support is to improve quality of life with coping strategies. These can include cognitive behavioral therapy, relaxation techniques, hypnotherapy, and distraction techniques. It is not uncommon to use these supports in addition to medications for a holistic approach to treatment in gastroparesis. It's often not enough alone, but it can be very helpful as an adjunct to increase the likelihood of efficacy of these medications. So how do our patients do? In pediatrics, kids do really, really well. Overall, pediatric patients experience resolution of their gastroparesis over time, just time alone, which is extremely different than the adult population who typically do require intervention. The mean overall symptom duration in children is about 14 months, and in infants it's even lower, right around 5 months. So pretty short period of time to just resolve without any intervention. So in one study, over 80% of the patients had resolution of symptoms within a year. Things that we know increase your likelihood of improvement with time alone include this post-infectious etiology. We typically think of it as temporary and transient, and so those patients tend to get better with time and maybe some mild supports. Patients who are younger in age, like I said previously, the infants usually only last about 5 months, and a positive response to Prokinetic. So patients who are put on a medication like erythromycin tend to do better and able to wean off in a quicker period of time. So this is a proposed approach to pediatric gastroparesis, which was published in Gastroenterology and Motility in 2019. It's a pathway that can help sort of guide you in treatment and diagnosis for patients that you think might have gastroparesis. So, of course, starting off with the initial possible symptom that the patient might have gastroparesis, and then going on from there to say, like, okay, do you think that there's any causes of gastroparesis, or does this seem pretty straightforward? And, you know, probably in the pediatric population, something along the lines of idiopathic or post-infectious. In that case, you order your gastric emptying scan, like we said earlier, with the hopefully standard study of the 4-hour solid food, and then you confirm your diagnosis. From there, the next big step is understanding what nutritional status these patients are at, because that will really indicate how, you know, aggressive you need to be in treatment upfront. If the nutritional status is stable or okay, and there hasn't been significant weight loss, starting with the diet changes first is a really good first step. Sometimes, again, it's very hard to do, or the patients feel like it's not helpful, and so that's when you would consider prokinetics, obviously in combination with the cognitive behavioral therapy like I talked about previously. If nutrition is compromised, there's been significant weight loss, well, you start off the bat with prokinetics and cognitive behavioral therapy, and then quickly advance to some of the more invasive treatments like Botox injections, the tube feeds, or TPN in very severe cases. Overwhelmingly, if the nutrition is compromised, the number one goal is to rehabilitate nutrition, because this will help the gastroparesis as well, while you also figure out what underlying treatment they need for the primary diagnosis of gastroparesis. If any of these steps fail, additional secondary approaches can be considered as adjunct diagnosis or therapy. So again, down here, we talk about the secondary approaches. So do we need to do different types of studies to look at the motility of the entire gut, like the ADM, or a whole colonic manometry study? Do we need to do surgical interventions? Do we want to think about this neuromodulation, which is newer? So this is a really easy approach to pediatric patients with gastroparesis, and a really straightforward way to differentiate what types of patients and what types of treatments you should start with. So now back to our patient, what happened? So she was started on erythromycin 3 times a day. Like I said, it's pretty much our first choice because of the low side effect profile as well as the efficacy in these patients. She had decreased vomiting, but did have continued nausea and discomfort with food. She also saw our GI psychologist, who initiated cognitive behavioral therapy and other techniques to help with understanding and compensating with these persistent symptoms. And then she had some as needed ondansetron added that did significantly improve her nausea, where she was able to then eat full meals. She was able to gain back her weight to her pre-illness weight. And over that period of time of, anywhere between 3 to 12 months, she had a repeat emptying scan, which normalized, and she was able to wean off her medications without persistent symptoms. This is a very typical timeline for our patients. This is common for pediatric patients in general, especially since majority of them are temporary and resolve with time. So in summary, the most common presenting symptom of pediatric gastroparesis is nausea, but kids can also present with more severe symptoms such as vomiting, early fullness, abdominal pain, and weight loss. Majority of patients in pediatrics are idiopathic or post-infectious. The gastric emptying scintigraphy is still the gold standard for diagnosis, despite some of the debates since there's no normative values in pediatrics. We typically start treatment with prokinetics or sometimes diet, but time alone is actually sufficient in pediatrics for treatment, and the majority of pediatric patients improve with 1 year of onset. I have references here if there are any questions in the future about where some of this data comes from. Thank you so much.